Okay, so any questions from the last section we talked about antibiotics?
That would take up the whole class.
That would take up the whole class. Okay, perhaps we shall wait until the end then. Do you guys want to? Okay. So I went ahead and combined the two ENT sections together just into one PowerPoint so I can just keep going through it. So if you guys may need to switch through partway, just FYI. So the first section we'll talk about is more antibiotics. Yay. Okay, we'll talk specifically about some of the indications, and you'll see that as we go through things like pulmonology and we talk about pneumonias and things like that, these antibiotics are going to come up again and again, and this is kind of the format that they'll be in. We'll talk a little bit about the disease state and then what the common organisms are and then what antibiotics we're going to be using to treat them, because that's one thing that a lot of preceptors really like you guys to know are things like, what's first line treatment for this, what's second line treatment for this if they're allergic to something. So this is good information to have. This is more clinically actionable information, I guess. So the first thing we'll talk about is acute otitis media. Certainly a lot of the causative organisms here are going to be viral. So, again, antibiotics are not always going to be your best choice here. And not a lot of antivirals that'll be appropriate for this indication. If you do see that a bacteria is involved in these infections, most oftentimes you're going to see things like strep pneumo. H. flu is somewhat common, but less common as things like vaccines, vaccination rates change. And then Moraxella catarrhalis is another one on this list. The way that we're going to be treating this is getting away with pretty simple antibiotics. So one thing that we can do, even though that things like strep pneumo resistance is a real issue, is we can pump up the dose of our drugs in order to overcome that resistance. And so this is one case where you can utilize high dose amoxicillin in order to overcome resistance from strep pneumo. So normally for most indications for things like amoxicillin, you might see 45 milligrams per kilogram per day or something like 50. Here we're using 80 to 90. So it's pretty well increased dose, but we're also trying to hit kind of a little bit more difficult area to treat. So because of that and the resistance issues, that's why we're pumping up our dose here. Again, don't memorize the dose, just know that we're using higher doses here because of those reasons. If you were to have someone who's having, say, a very severe infection, or maybe they had been on previous courses of amoxicillin that has, they've failed therapy and they're still coming back and they're having this, this really bad infection, or perhaps if you are really concerned about resistance rates in your area, this is when you can actually step up therapy and add on clavulanate, which is what? Yeah, it's the beta-lactamase inhibitor. So by adding on beta-lactamase inhibitor to your amoxicillin, you increase the coverage of it, you increase the ability to overcome some of that bacterial resistance. So that's where you can step up your therapy. So you don't necessarily want to jump to augmentin right off the bat, but certainly if you have someone who has a history, say, they've been on a couple of previous courses of antibiotics and you're worried about them having a resistant pathogen, that would be a good choice, right? Or if they failed therapy with amoxicillin, then you want to step up your game with this. Some other options, if you had some reason you could not give amoxicillin, say they had like a really severe allergy, you can get away with something like Ceftonir, which anyone remember what generation cephalosporin that is? That's a third generation cephalosporin. Hopefully you guys know it was cephalosporin, right? Yes. Or azithromycin might be another option. Now, azithromycin, obviously we were worried about resistance here as well, so that is definitely not going to be our first choice for this, but if you kind of can't use anything else, this might be a good option for you. Now, if they are still failing therapy, or perhaps they're not able to take oral medications for whatever reason, there may be cases where you can utilize something like ceftriaxone, which again is another third-generation cephalosporin that has the benefit of being able to be given parenterally. So in some cases, I'll see kids who, like in the peds ED, I'll have kids who come in and they just cannot take oral meds. They just, they'll either spit them up or they just can't tolerate them, too much nausea, vomiting, in which case they may come in for 3 days worth of ceftriaxone. You guys remember that ceftriaxone has a longer half-life, so we don't have to give it once a day. Even though you'd be treating for a longer period of time with something like an amoxicillin, you can get away with something like 3 days of therapy with ceftriaxone because the half-life is so long that's enough to cover them for that period of time. Moving on to bacterial rhinosinusitis, you'll see kind of similar organisms are going to be here with the addition of some additional gram-positive bugs, things like Staph pyogenes or Staph aureus, Strep pyogenes. Keep in mind here that a lot of cases of rhinosinusitis are typically going to be viral in origin here, and really you need to have symptoms for a long enough period of time for you to really start to suspect that they have a bacterial etiology here. So again, they're going to have symptoms for something like greater than 10 days. That is going to be a good sign that it is bacterial in nature. And then you'll typically see worsening symptoms 5 to 6 days in or so. Here you're going to see that, again, the sinuses are going to be kind of a tough area to penetrate, and so instead of using something like amoxicillin by itself, we can actually just go ahead and skip straight over to using Augmentin, which again is adding that beta-lactamase inhibitor. And this is going to be useful as well for resistant strains of influenza that is more likely to be producing beta-lactamase. In this case, if you were unable to utilize amoxicillin, you can get away with using some combination therapy, so something like clindamycin, which remember has really good coverage against what type of bacteria? Gram-positives, right? So clindamycin is good for gram-positives, but you really are not going to be seeing a lot of gram-negative coverage there with that drug, so that's when you add in something like another cephalosporin, like cefixime, or you could just use levofloxacin by itself and kind of get good coverage for that. But again, levofloxacin, similar to the macrolides, is not something you want to jump to because, again, of increasing resistance patterns. And then looking at acute pharyngitis, so this one's a little bit different because we're not really so concerned about the actual bacterial infestation. We're more worried about the kind of the secondary complications of pharyngitis. You'll see a lot of times that the majority of the cases are going to be caused by group A beta hemolytic strep, if it's not being caused by a virus. That's usually the number one bacteria that's there. The idea of treatment here, though, is the fact that we're going to be trying to prevent this acute rheumatic fever and other suppurative complications. Because again, a lot of people may just be strep carriers and they may not actually be acutely symptomatic. But for those that are becoming symptomatic, we want to prevent this secondary complication. And a lot of times we have rapid strep tests that are available. So especially like in the ED, you used to get, especially in towards the wintertime months, see rapid streps being done on almost every kid coming in complaining of sore throat, and that actually gives you a much better idea of what type of bug you're dealing with. I'll tell you right off the bat whether you have strep or not, and then you can initiate appropriate therapy for that. So if it comes back negative, you may not necessarily need to start any antibiotics, but certainly if it comes back positive, then yeah, you would want to go ahead and start treatment. The drug of choice for this indication is going to be amoxicillin by itself. This one you can see that normally amoxicillin being concentration or time-dependent killer. The time-dependent killer. This one, because this is kind of an easy place to treat, you can actually get away with just using a little bit higher dose just once daily. So this is kind of an odd dosing for amoxicillin. Normally you're going to see multiple times a day, but this is one that the guidelines back up that you can just use once daily for 10 days. Again, don't memorize the dose, just know that that dosing is a little bit different for this indication. Other alternatives, if they were not able to take oral medications, would be that bicillin that we talked about previously, that benzathine G penicillin. It comes in that kind of milky white suspension that you can inject intramuscularly, and it has a nice long duration of action. Will cover you for a similar time period as the amoxicillin will. Other alternatives will include things like cephalexin, clindamycin, or azithromycin. And then moving on, we certainly have some otic antibiotics that are available, or things that can be given via the otic route. A lot of times you're going to be seeing combination drugs of this, so you can see them mixing an anti-infective plus a glucocorticoid. So this is good for things like otitis externa. Oftentimes I'll see a lot of kids over at Nemours like that are status, they're post-op from having tubes placed in, and they use this for prophylaxis of an infection. But some of the things you'll see commonly are ciprofloxacin is a common one being used, ciprofloxacin, dexamethasone. So again, dexamethasone being like glucocorticoid. You're adding on top of there to help decrease a lot of that inflammation, which is good like post-surgery, or if you just have really bad infection and things are getting really inflamed there. And then another common one would be a combination of neomycin, polymyxin B, and hydrocortisone. And then ofloxacin is another one we have available by itself. So resistance isn't really such a big issue with these otic medications, because again, you're giving a much higher concentration right at the source of action. So the doses that you're using, the concentrations you can achieve relative to systemic administration is much higher. So you can usually overcome a lot of resistance that way. And so this is not such a big issue that we see here. So again, otitis media, externa, some things to note for some of these medications. One, neomycin probably has the highest degree of hypersensitivity. So if you are worried about that, or if they have a previous history of allergy, it's probably to the neomycin itself. And then the other thing to note is, and we talked about the polymyxins, you guys remember that it had a lot of toxicities associated with it, especially when administered systemically. Polymyxin B is one you want to not recommend for patients to have a ruptured tympanic membrane or if they have tubes in place. And the reason for that is because when you lose that barrier, some of the polymyxin can get towards the inner parts of the ear and can actually damage some of the hair cells there. And so it can actually cause some degree of hearing loss. So similar to what you would see applied systemically, you can get the same issue there if you don't have an intact tympanic membrane. And then a very commonly prescribed one is going to be that ciprofloxacin dexamethasone because it's very effective and it's very good at what it does. But in a lot of cases, it's very expensive. And if the patient's insurance coverage does not cover it, then you can be in trouble. Because again, if they can't fill the medication, there's no point in prescribing it. So one of the things we'll actually do in clinical practice is, and this is much cheaper, and also useful in case you have drug shortages of the Otic formulations, we can actually prescribe ofloxacin and dexamethasone. So ofloxacin Otic, and then the dexamethasone ophthalmic, and you can give that via the Otic route, and you get basically the same action there. You're just using 2 products instead of 1, and oftentimes is much cheaper. Okay, moving on to the ENT antifungals that we may see available. Some of these we already covered, so things like ketoconazole is a fairly common one. We remember that this is going to work by inhibiting CYP450 within the fungal cells to help prevent that cell wall synthesis. Again, same thing can be happening to our cells as well, especially when you have the CYP450 being interacted with there. You guys remember which CYP enzyme is the big one that's affected here? 3A4, remember, that's the big one to remember with a lot of these interactions. Other things you can see with systemically administered ketoconazole is going to be things like QT prolongation, which we talked about that, blocking that potassium efflux channel, and certainly is potential for things like hepatic injury. But in general, it's pretty well tolerated for the most part. So you can keep in mind that if you have other drugs on board that are substrates for CYP3A4 that are being metabolized by that enzyme, this is going to inhibit that and cause those levels to increase, and so you run the risk of having more toxicity from those drugs. Again, contraindications are really the big relative ones are going to be other things that are substrates to CYP3A4 or that prolong QT interval as well, because again, when you have multiple drugs on board that can do that, it's going to increase your risk for arrhythmia. So just check your medication list before prescribing this systemically. If it's topical, it's not really going to be such a big deal, so you wouldn't have to worry about that necessarily because there's no real systemic absorption going on. And then another big one, especially for ENT uses, is going to be nystatin. You guys remember that this one is non-absorbable. So it's really important to remember that because you're not going to see a lot of systemic side effects from this drug because of the fact it's not absorbable. So whether it's swish and spit or swish and swallow, whatever it happens to be, you're not going to see a lot of systemic effects from this. And so again, this one's going to help to increase cell wall permeability to cause the fungal cell death. And the most common thing you're going to see being used, this being used for is going to be oral thrush or candidiasis, right? So especially I've seen it a lot as prophylaxis in patients who are immunocompromised. So I'll see this a lot in patients who are, say, receiving chemotherapy and things like that. They'll use this as a prophylactic medication to prevent thrush from developing in the first place. Okay, and we'll talk a little bit more about antivirals. I know we didn't cover that in the antibiotic section, but we'll talk about them here a little bit more in depth. So at some point, we'll probably talk about HIV, and we'll talk more about a lot of these approaches to therapy. But there's lots of different ways that medications can interfere with viral replication. The big thing that we're going to be seeing with these agents that we're going to talk about, and these are the more common ones you're going to run into, are going to be preventing duplication of the viral DNA. So you're going to see a lot of things that are going to be getting incorporated into the viral DNA that prevent elongation of that and eventually lead to the viral death. But there's lots of other ways. We'll probably get more into this if we ever talk about HIV. The big ones we'll probably talk about as far as the viruses go are going to be things like herpes simplex, varicella zoster, and then cytomegalovirus. Again, cytomegalovirus is something you're typically going to see more in your immunocompromised patients. And then the herpes we'll focus on here is mainly going to be the type 1, since that's going to be affecting most of your ENT type areas. So I don't want you to be able to replicate this on a test. That'd be kind of mean. I had to do this in some of my pharmacology classes. We actually had to do structures like that. It was pretty painful. But the thing I want to focus on here is that one, what do you notice about the structure of these medications? What do they look like?
6 and 5 to
Yeah, they'll kind of like look like base pairs in DNA, right? That's exactly how they're supposed to look, because they're going to get incorporated in. The big thing here is that they lack that sugar moiety, so they can't. So they can get incorporated into the DNA, but they can't get elongated because they lack that sugar backbone to cause that to occur. So basically, these are just masquerading as base pairs, so they can get incorporated into the DNA of the virus. Notice here as well that the drugs on the right side are going to be prodrugs of the drugs on the left side. So if you look, you can see the structure between something like valacyclovir and acyclovir are very similar. Similarly for valganciclovir and ganciclovir, very, very similar, it's just a prodrug. And the main purpose of this, you guys remember prodrugs, what's special about them?
They have to turn into metabolites.
Yeah. Typically they don't have their own activity of their own. They have really no therapeutic activity, but once they get converted over, they get metabolized into the actual active compound. That's when they can start to work. The big reason why we do this is so that we can increase GI absorption and increase the bioavailability of these drugs. So something like acyclovir, while it does have some bioavailability, it gets much better when you get something like valacyclovir. It's able to kind of withstand the rigors of going through the GI tract and getting put through the liver, and then it can be converted into acyclovir. So again, acyclovir and valacyclovir, Zovirax and Valtrex, respectively. These are going to be guanine analogs. But again, they're lacking that sugar moiety, so that way they cannot continue to add on to that within the virus itself. So again, it's going to lead to eventual viral death. Big indications for this are going to include herpes simplex and varicella zoster. Some of the resistance you may see pop up here with the virus itself is they have an altered thymidine kinase that can actually bypass this mechanism and prevent the drugs from working quite so well. But typically, resistance is not a huge issue with these medications for the most part. Again, looking at the bioavailability, you can see that acyclovir is around 22%, and then you can get much better bioavailability with valacyclovir or Valtrex, which has as a prodrug is about 70%. So you're going to see that the adverse effects of the antivirals we're going to be talking about today are pretty similar across the board. Big thing you're going to be potentially seeing is nausea, vomiting, rash can occur. Notice the renal issues here. You worry about a lot of these drugs precipitating out in the renal tubules. So maintaining hydration is really important to maintaining good renal function. Otherwise, you end up having the crystals settle out of solution and potentially lead to some interstitial nephritis, things like that. And then the other thing you want to worry about is going to be the CNS effects. So particularly like older patients in particular can be more susceptible to this, but you can see things like seizures, delirium. And then the other big thing is going to be bone marrow suppression. You're going to see this more with something like valacyclovir, valganciclovir and ganciclovir, but you can have some bone marrow suppression here as well with these drugs. Has anyone heard of probenecid before? It's not something you see ever used clinically anymore, but it used to be a drug. Basically what it does is it blocks tubular secretion within the kidneys, and so they actually can prolong the half-life of many drugs. And so this actually has an interaction to decrease renal clearance, but clinically you're never really going to see probenecid being used. It used to be utilized to help increase the half-life of things like penicillin, so you have to give fewer doses. But like I said, clinically we don't have to do that anymore. Important to note here that you want to give these antivirals sooner rather than later. The sooner you get them on board, the more likely they are to have some therapeutic efficacy. And so, like in instance here, when we give it within the first 24 hours, they can help to shorten the acute illness, but not necessarily clear the infection itself. And keep in mind that even if someone is on these medications, are they still able to spread certain viruses? Yes, absolutely. So even if you're on your Valtrex and you're having an outbreak, you can still spread it to other people. So that's an important thing to counsel patients on. Similarly, we have famciclovir and penciclovir. Again, very similar mechanism, just gets incorporated into the viral DNA but prevents any more elongation. And very similar toxicity to that and very similar indication. So note here, penciclovir has such poor bioavailability that we'd only give it IV, whereas famciclovir, as being the prodrug, is available to be given orally. And then valganciclovir, ganciclovir, guanine analogs, it's very, very similar. These are typically going to be more reserved for your immunocompromised patients, especially those that have cytomegalovirus, so transplant patients who are on a lot of immunosuppressants, or patients receiving chemotherapy, or AIDS patients, things like that. Those are going to be the more at risk here for a lot of the cytomegalovirus. Again, the side effects are a little bit worse here with these drugs. That's why they're mainly relegated to more kind of invasive infections. But you see more neutropenia, thrombocytopenia, so that's that bone marrow suppression popping up there. And certainly the CNS effects can be problematic as well. And typically, you'll see that about a third of patients actually have to stop intravenous treatment just due to the side effects. So it can be pretty nasty depending on your patient. Another antiviral agent is going to be foscarnet or foscavir. This is going to be inhibiting the DNA polymerase, the viral DNA polymerase itself. This one is really going to be seen a lot more for kind of resistant viral infections. I've seen this only used a few times in really sick patients who are basically resistant to all other agents. This one is only for IV administration and really needs to be renally dose adjusted. And it's pretty nephrotoxic itself, so it's one of those things that you really want to reserve as kind of a last-ditch effort, because the side effects can be worse than the actual infection in some cases if you were to give it to someone else who's healthier. But some of the issues you can see is the nephrotoxicity, and then also it can chelate cations within the blood, so you can see hypocalcemia, hypomagnesemia, hypokalemia, so it can be a big issue. If you imagine if you were to give this type of drug to someone who is on, say, a bunch of immunosuppressants, or were increasing the QT interval, all these electrolyte abnormalities can just lead to worsened risk for arrhythmias and things like that. So think about things that are affecting your electrolytes, especially magnesium and calcium and potassium, also affecting patients who are having anything prolonging QT intervals or any other thing that kind of predisposes them to arrhythmias. Again, you see this used a lot for cytomegalovirus, and then also potentially some resistant HSV or shingles cases. Again, adverse effects, we already talked about some of them, but again, you can see the CNS issues, see the bone marrow issues, and again, the renal impairment is probably going to be the other really big thing to note there. Okay, one other kind of miscellaneous topic we'll talk about, and just kind of put this in a random spot, is going to be pregnancy categories. So if I were to say something has a pregnancy category A, what does that mean to you guys? Is it okay to give to a pregnant lady?
Mm-hmm.
Think yes?
Yes.
Yeah, probably based on the slide, absolutely is totally safe. Totally good to go, no issues. And the way you'll see that these are differentiated, and you'll see why we don't really use these anymore, is that you're looking at both animal studies and also human studies to look to see what kind of adverse effects we have on the fetus, right? In a lot of cases, you're going to see that, especially like when something like toxicology. So my discipline of toxicology, in a lot of cases, if you have, say, like a pregnant mom who decides she wants to kill herself, sometimes you have to give them drugs that are not necessarily category A or B, right? And that's because if the mom dies, fetus probably isn't going to do well either, right? So in a lot of cases, you may not have options. Sometimes you have to weigh the benefits versus the risk with these pregnancy categories. But A is going to be totally safe. There's no animal studies or human studies that really show that there's any kind of risk to the fetus itself. So A's are good to go. B's are also really good, right? So B's mean that in general, animal reproductive studies have failed to show any kind of risk, right? And there's really no adequate information saying that in pregnant females you see any risk. Or the other case could be that animal studies showed that there may have been some risk, but the human studies haven't really borne that out, okay? And how easy is it to hold a study on pregnant females? You can't do it, right? So a lot of this is going back to and looking at just kind of anecdotal information, or looking at case studies, kind of going back retrospectively and saying, okay, well, these women happen to have received this, this drug during this time period, and they didn't have any problems with it, right? So a lot of these things are looking at historical data. We can't necessarily do ethically a study where I have a bunch of pregnant ladies and give them half of them one drug and half of them no drug. That's not really all that ethical. So this is why the data that we have available is oftentimes really spotty for this stuff anyway. But category B is still going to be pretty good to give to pregnant ladies. So this would be something like, amoxicillin falls in this category. Something like like doxylamine is another good one. We'll talk about doxylamine a little bit later. But these are, again, things that have shown no risk to humans, may or may not have shown risk to animal studies. Then you get to category C. And category C is basically like a big like shoulder shrug, like we don't really know what it does, right? We have animal studies that maybe have shown adverse effects on the fetus, but we don't really have enough good information to say whether or not it's going to be a problem for humans. And so if you had to imagine the category that most drugs fall into, you might say category C, right? And C is clinically not super useful for you as clinicians saying like, well, should I give this medication to this pregnant lady? Most of the time the answer should be no. You try to avoid giving medications whenever possible, but you'll see that the majority of medications would have fallen into this category C, and again, that doesn't help you out clinically. The other two categories are going to be ones that are definitely more on the side of harm. So category D are going to be things that we know have documented negative effects on the fetus, but in some cases, the risk to the mother might be so much that you may, the benefit-risk ratio may fall on the side of you may want to give it in some cases. So say, for instance, you have a patient who has very severe bipolar disorder. They need their lithium, otherwise they are at risk for harming themselves, harming others. That may be a case where you say, well, I know there's possible risk, but the mom needs it, right? Otherwise, bad things can occur. And then you have category X, which is just that there's absolute risk. There's really no situations where there's benefit in order to receive this. This will certainly be something like Accutane, otherwise known as isotretinoin, which is a medication we'll talk about in the dermatology section. But we know that's absolute risk. No one's going to die from acne, probably. So this is a situation where there's really no benefits to giving it, so this is category X. Does that make sense? The different categories?
Mm-hmm.
Yes?
Kind of like a side note, I've heard that if you used Accutane like in younger years and then later you want to get pregnant, it has some kind of effect. Is that true?
I'm not aware of any long-lasting effect. Certainly there might be a period where you have some, kind of a washout period where the drug is, being metabolized off, but I'm not aware of any kind of long-term, like years down the road type of effects that I'm aware of. But if someone finds any other information, I'll be happy to hear it. Yeah. So the thing is that you'll see that if you're looking at a lot of drug references, older drugs will still have their pregnancy categories associated with them, but for the most part, they're being removed because they're not super useful. So again, seeing category C is not all that useful for you or your patients. And so what a lot of things are being replaced with are these risk summaries, where basically they're looking at all the available literature, and they basically put a synopsis out there for you to say like, well, here's at least what the studies have said. Here's what, here's the patients that we know of that have received this drug and what happened to them. And that gives you a much better ability to kind of make a clinical decision to be like, well, my patient's not actually anything like this. Maybe it's okay for them to receive this or not. So you'll see this a lot with a lot of the newer drugs that are coming out. They won't really have a pregnancy category associated with them. Okay. Any questions on that? Okay. Moving on to some more ENT medications. So these would be some of our anti-inflammatories you might see being used. So first thing we'll talk about are going to be our salicylates. The main drug falling in this category is going to be aspirin. If you ever see ASA as an abbreviation for aspirin, that's what it stands for, is that acetyl salicylic acid. ASA is a little bit easier to say. This is a medication that has good oral absorption. It's metabolized through the kidney or through the liver and then eliminated through the kidneys. Does have some crossing of the placenta and the breast milk, so you can have fetal exposure to moms who are receiving this. The big thing to note with this medication, we've talked about NSAIDs before, and NSAIDs, non-steroidal anti-inflammatory drugs, work by blocking what enzyme? Yeah, cyclooxygenase, otherwise known as COX. And so, was it a reversible or irreversible inhibitor? It's actually a reversible inhibitor. So NSAIDs are reversible inhibitors of cyclooxygenase. The big difference here with aspirin is this is actually an irreversible inhibitor. So this is what we call kind of a suicide inhibitor, where especially with things like platelets, once they were being affected by aspirin, until you get rid of that platelet and make a new one, that effect is going to be sticking around. Okay. We'll talk about why that's important just a little bit. But these are non-selective as well. You'll see that there are certain ones that have more selectivity for certain cyclooxygenase enzymes, but aspirin itself is non-selective. So it can affect COX-1, 2, which are clinically the two big ones that we'll see of clinical importance, but COX-3 is also available as well. It's seen more in the CNS. We'll talk about a medication that affects that. So you'll see that different therapeutic activities can be achieved by getting different doses of the medication itself. So if you're looking at something like the lower doses, so something like a baby aspirin is how many milligrams? Anyone know? Yeah, 81 milligrams. So it's that 0.08 grams up to 325 milligrams. You see mainly just the antiplatelet activity. And so again, your platelets, in order for them to have their clotting action, they rely on that arachidonic acid pathway and cyclooxygenase. So by giving a suicide inhibitor like aspirin, that'll bind to that and prevent, it kind of puts that platelet out of commission until it's been recycled and you have a new one. So that's where you see those antiplatelet effects. That's why you can get away with using baby aspirin doses for adult patients in order to help prevent things like MI, right? Obviously complications, biggest risk you're going to be seeing there is things like bleeding, okay, because you're preventing your platelets from clotting effectively, bigger chance for bruising, bleeding, etc. When you start to get to higher doses, so something like 650 milligrams up to a gram, this is where you're going to see more of the antipyretic and the analgesic activity. So this is where we're going to be seeing a lot of your dosing sitting for, if I was getting it for headache, if I'm getting it for fever. Obviously, you still have the bleeding risk because those platelets are still going to be inhibited, but you can also end up seeing some other issues as well. So if I was taking aspirin pretty chronically, cyclooxygenase is really important for producing things like, the mucosal barrier on the stomach. And so if I inhibit that, I can lead to kind of weakened barriers there and less of that mucosa. So I can end up seeing GI issues, potentially GI bleeds can occur, perforation in some rare cases. And then hypersensitivities can also pop up. Certainly any dose it can happen, but you're more likely to see them when you start to get the doses pumped up a little bit higher here. Anyone know a common side effect of aspirin? It's kind of unique to it. Yeah, the tinnitus is the big thing you can see there as well. So some people will get this even at therapeutic doses, but certainly as you start to bump up the doses even higher, that's where you can start to see that ear ringing. Some people complain of like a really kind of muffled kind of sound. They can't really hear much. Certainly from the tox side of things, when I see a lot of patients overdosed on aspirin, this is something that you're looking for. If I'm trying to talk to them and they're like, huh? Like I know that tinnitus is kind of happening there. As you get, and certainly you can see these higher doses sometimes being used for things like rheumatologic conditions and things like that, where you're going to be needing that anti-inflammatory activity. And then as you get into higher doses, obviously is where we get to see more of the overdoses, and we call this salicism. You can see lots of things like this hyperventilation, alkalosis that can occur, and eventually they get this kind of overwhelming metabolic acidosis, but I won't get too far into that. So mainly the top part of this chart is the main thing to focus on. So obviously contraindications would be things like bleeding disorders. So you don't want to add insult to injury, make them even more prone to bleed. In some cases you may see some pregnant patients receiving this, but it's not very often. It's thought to maybe help with things like preeclampsia, but clinically I've not seen too much of it being used. And then the other big thing to note here is going to be that you do not want to give salicylates to children who've had fever associated with viral disease because we worry about the increased risk for Reye syndrome. Has anyone heard of Reye syndrome before? Okay, it's pretty bad, so you want to be definitely something to make note of, something not to avoid, or something to avoid in these younger patients. So I have a couple more slides about it because it's so important. So Reye syndrome basically is this fatty liver encephalopathy that can occur, and so again, this is for children less than 15 years of age. So usually like 16 is kind of like cut off for administering aspirin. And if not treated, you have a mortality rate of like 50%. So it's very, very significant if it's not caught early on. You can end up seeing different phases of it, which I'll show you in just a second, but include things like progressive CNS damage, hepatic injury, hypoglycemia, very significant hepatic issues like fatty liver can develop into full-blown hepatic failure, mitochondrial dysfunction, all kinds of bad things happening here. And you typically are going to be seeing the patients are going to be kind of in a post-viral case where they have like a fever secondary to like an upper respiratory tract infection or flu or chickenpox, and this is where they're most likely to induce this Reye syndrome. So you see the 5 stages kind of starts off with things like rash on the hands and feet, vomiting, high fever, and then as it progresses, you're going to see this encephalitis where they get altered mental status and just not acting themselves. That's probably the first place where parents are really going to start to notice something's going on, because if you notice the stage 1, like that could just be related to whatever illness they had previously, right? So things are starting to get worse. You get this hyperventilation, this fatty liver that can occur, and eventually to things like cerebral edema, seizures, multiple organ failure. So again, you want to avoid this as much as possible. So usually less than 16, I just don't even recommend aspirin across the board. Anyone know why I put Pepto-Bismol on here?
You're not supposed to give it to children.
Okay, do you know what's in Pepto-Bismol? It's a good guess. So it's bismuth subsalicylate. So it does contain salicylates in it, even though it's not strictly aspirin, but so that's another common one that people don't necessarily associate with being an aspirin-containing product. So again, it's a big one to make sure we recommend. I know my mom's probably given this to me a ton of times when I was a kid, so shame on her, but fortunately I survived. Again, main things you'll see this being recommended for, obviously headache for the analgesic activity, fever is going to be the other big one. Obviously, since this is an over-the-counter product, patients are going to be self-medicating with this in a lot of cases. So it's important that they're being educated on things like, taking lots of fluids, and if they're not getting better over the course of several days, like they probably need to come in to see if something else is going on. Otherwise, they might just keep treating themselves and run into issues. Has anyone heard of Goodies powders or BC powders? What are those? They're also aspirin products, but a lot of people don't necessarily, especially, it's kind of a southern thing, so if people aren't from the South, they probably have not heard of it. That's been my experience. But essentially, they're these like little kind of wax paper sachets that contain powdered aspirin, and so they'll basically just drop that into a drink, drop it into some water, mix it up, and take that. And a lot of older patients don't necessarily associate that with being aspirin either. And so I have an interesting case where a patient would, every time he was having chest pain, he would decide he'd go ahead and take a BC's powder, right? So this is something his doctor told him. So he would take a BC powder. Didn't really realize it was aspirin. So kept having chest pain, kept taking his BC powders, and he's like, "Oh, I got to call 911 at this point. It's not getting better." So he calls 911, and the ambulance gets there. They take a medication history, but he never says aspirin. So what does the EMT give him? Give him more aspirin, okay? And he gets into the ER, and what does the resident give him? More aspirin. So then all of a sudden he's like, I can't really hear you. What? All of a sudden he's salicylate toxic on top of having some angina there. So again, make sure people are aware of what OTC products that they're actually taking, because a lot of times they may not necessarily associate them with being medications. And obviously, if patients are taking other anticoagulants, make sure that they are aware of that. They'll be looking for things like increased bruising, bleeding, etc. So moving on, the other pretty common antipyretic analgesic you'll see in common use, because this is an OTC product, obviously, is going to be ibuprofen, otherwise known as Motrin. Again, this is a non-steroidal anti-inflammatory drug. We'll talk about some of the other prescription products a little bit later on in one of the courses, but this is probably one of the other big ones you're going to see being used, especially for self-medication and whatnot. Again, this one is going to be reversibly inhibiting cyclooxygenase 1 and 2. Doesn't really have any preference for one over the other. So you're going to be seeing similar side effects to aspirin, except for you don't really see a lot of the bleeding risk, because the reversibility of it means that your platelets, as soon as the drug's gone, platelets are functioning normally, right? So the bleed risk is not such a big deal, but certainly still see a lot of the GI toxicity that can occur there. So that is something definitely to note, especially if they're taking it kind of around the clock for a chronic period of time. Again, other things you want to note whenever you're administering something that prevents prostaglandin synthesis is the idea that if you have patients who are dependent on those prostaglandins for their renal function, that can be inhibited. So certainly, have you guys covered any kind of like renal pathophysiology, anything yet? Okay, so essentially what's happening is that in your glomerulus you have an efferent arterial, have an afferent arterial, right? So the efferent's leaving the glomerulus, you have an afferent arterial going into the glomerulus, right? And so if I were to, and prostaglandins are really important for opening up and having a vasodilatory action on the afferent arterial, right? So if I were to give something that takes away those prostaglandins from being produced, all of a sudden the afferent arterial is going to start to close down, right? And so that can be really important for patients who are really dependent on that in order to help maintain their normal kidney blood flow, right? So that's why NSAIDs can have an interaction with patients who are on antihypertensives, because it can actually worsen their hypertension because their kidneys feel like they're not getting enough flow. We'll talk about that more when we get to the next section after the test, but just realize that there is an interaction there. It can help blunt the effects of your other antihypertensives, can worsen your hypertension. And again, that goes along with that acute renal failure, increased creatinine clearance. That's really only for patients who are dependent on those prostaglandins. So usually your older patients who have kind of chronic hypertension or CHF, things like that, a healthy patient, they're really not going to have any appreciable effect on their kidney blood flow and their creatinine clearance. Again, most of the interactions you're going to be seeing here are going to include kidney interactions, so certainly things like your ACE inhibitors, which we'll talk about next section. Look at things that are renally eliminated, like lithium is a big one, so it can actually increase your lithium levels, can be an issue there. And other things like methotrexate as well. And then obviously you will have potential risk for increasing the anticoagulant effects of other medications that are on board. But again, this is only going to be when the drug's actually around. So whereas with aspirin, it has kind of an irreversible effect that'll stick around for much longer than what the drug's half-life is, Motrin and other NSAIDs are only really going to have this bleeding effect while the drug's on board. Anyone know why we want to prevent, we'd be cautious in giving this to patients with asthma? So one of the things you worry about is that some patients are really dependent on, are more sensitive to leukotrienes. We'll talk about this in the asthma section, but essentially what happens is that by blocking cyclooxygenase, you kind of shunt the pathway over to producing more leukotrienes, which can actually cause cause bronchoconstriction for asthmatic patients. So if you ever hear about a patient who has, say, like an aspirin allergy or an ibuprofen allergy, and their reaction is that their throat closed up or that they had really bad asthma, that's probably what's happening there. So again, some patients are going to be more prone to that, but it's important just to ask questions. Like for someone like me who has asthma that's more kind of allergen related, I wouldn't have any problems receiving NSAIDs, but certain other patients might be more predisposed to that. So that's why histories are so important for determining that. And then moving on, we have Acetaminophen, or Tylenol, as it's commonly known. Does anyone ever figure out, or everyone's curious where the brand name Tylenol comes from? The chemical name for acetaminophen is para-acetaminophenol. If you take the TYL and the ENOL out of that, you get Tylenol. So if you're ever curious and need to impress your friends, pharmacy knowledge, that's how you do it. So this medication here is going to be more selectively working against cyclooxygenase 3. So it's going to have different activity than you would see with something like an NSAID. So you're going to be seeing analgesic activity for sure, but you don't really get any anti-inflammatory activity. But because it also works on cyclooxygenase 3, you also get this antipyretic effect as well. So if you have someone who, say, like sprains their ankle, something like an NSAID, like a Motrin, is going to be better for that because you're having kind of local inflammation. But if I have something like a headache, Tylenol may be better for me because I'm really going to be more focusing on those kind of central activities there. I'd say that Motrin wouldn't be good for that, but just realize that there really is no anti-inflammatory action with Tylenol. It's really just the antipyretic effects that you get there. So certainly, what's the big organ you worry about being damaged with acetaminophen? Yeah, liver toxicity is going to be the big one you really worry about with that one. So again, this is why it's really important that, especially when you go to Costco, you can buy like a 55-gallon drum of Tylenol for like nothing. So it's really easy for patients to overdo it if they don't realize what they're doing. And so that's why you will see that they're not supposed to exceed more than 4 grams in a day, and they actually lowered that recommendation down. I think it's like 3,250 or something like that, that patients aren't supposed to exceed, because they were seeing that even patients who were taking 4 grams a day every single day were still developing some hepatic issues there. I'll probably talk more about this when we get to like a toxicology section, but just suffice it to say that Tylenol is hepatotoxic, especially in higher doses. Especially patients who are maybe already more at risk for developing hepatotoxicity in the first place, so especially like chronic drinkers who are maybe already have some mild hepatitis, like this can actually be they're more at risk for developing hepatotoxicity in the presence of Tylenol than you would be otherwise in otherwise healthy patient. No real contraindications to worry about. This is another one that's safe to use for pregnant patients if you absolutely have to. Yeah. Okay, moving on. Now we'll talk about some antihistamines. So we know that histamines are released from our immune cells. We talked a little bit about antihistamines when we talked about some of our ocular pharmacology. You see that's responsible. We're going to be talking more histamine in a more systemic response in this case. We know it's responsible for this triple response that occurs. So you see this redness that due to direct vasodilation, and then a wheal and flare, a lot of edema, a lot of redness kind of going around whatever the area of insult is. You see this with a lot of allergic reactions that can occur. A lot of it is due to histamine. There's lots of histamine receptors that are located throughout the body. The 2 primary ones that we'll end up talking about are going to be H1 and H2. H2 we'll see more in the GI section, because that's going to be more important for things like GI smooth muscle, GI mucosa, things like that, because it's actually is helpful for producing stomach acids and things like that. H1 is mainly the one we're going to be focusing on today for like ENT purposes. So for when you're talking about things like nasal secretions or mucus secretions, we're talking about vertigo and things like that. H1 blockers are mainly the ones we're going to be talking about, because that's the one mainly working up in the CNS. So H1 receptors, these are responsible for this post-capillary permeability. If you guys remember your secondary messengers, it works as phospholipase C pathway and the IP3 and DAG and all that. But essentially by increasing the permeability, making things more leaky, that's where you're seeing a lot of that vasodilation and that the edema occurring there. You're also going to see more mucus secretion, so certainly somewhat in the GI tract, but certainly in the bronchial tract, nasal tract. You end up seeing some increased smooth muscle tone. You also will make certain sensory nerves endings more sensitive, and then you also worry about things like bronchoconstriction as well. On the other hand, we talk about the H2 receptors being more predominant in the GI tract. It can also have some effects on things like contractility of the heart, but really the big thing you'll be seeing is being associated with is going to be this gastric acid secretion. We'll talk more about that in the GI section. There's also some H3 receptors thought to be more having to do with things like promoting wakefulness and whatnot, but we won't talk too much about this one. Just suffice it to say that maybe sometime down the future you may have drugs against H3 receptors, but right now nothing really clinically out there. Sorry. So when you have an H1 receptor antagonist, the big things we're going to be seeing from the peripheral effects. So again, we're going to be talking about central effects and peripheral effects of H1 blockers. Big thing we're going to be seeing here is that we want them to block the smooth muscle contraction, so both in the GI tract and the bronchial tract. They're also going to help block some of this rapid vasodilation that's occurring here. So the idea is we're going to be seeing decreased secretions, decreased mucous membrane secretions, hopefully decreased vascular permeability and edema, seeing decreased hives and also decreased itching. So by blocking those histamine receptors, we're going to hopefully deal with a lot of those allergic reactions that can occur when these are being released. From the CNS standpoint, you're going to be seeing a lot of these H1 antagonists are going to be working through multiple mechanisms. Primarily, a lot of them are going to have antimuscarinic activity. Because we talked about antimuscarinic activity before. Do you guys remember we talked about like Mazahatter, Rezabet, Trizabone, all that good stuff? Same thing's going to be kind of applying here. And so that's why for a lot of the H1 antagonists, sedation is going to be one of the big side effects. So anyone ever taken Benadryl, gotten sleepy? That's exactly what we're talking about there. And a lot of that's due to the antimuscarinic activity that you can see with those medications. It can be additive, especially if you combine it with other CNS depressants or if you have something like alcohol on board. And in fact, it is marketed as over-the-counter sleep aid. So doxylamine is going to be one of the ones you'll see there. It's usually found in Unisom. So other things you're going to see is that in some patients, they're going to be more prone to having restlessness and excitation, especially in children. And so it's something we call a paradoxical response, where basically you give a therapeutic dose of Benadryl to a kid and they get super wired and they're bouncing off the walls and you're like, they were supposed to go to sleep. What happened? Has anyone ever seen that before? Yeah, so it can be pretty nuts. I'm actually scared to ever give my kid Benadryl because I worry she's going to have that response. So even though we want to sleep, we're like, no, we'll just let her cry. And so certainly higher doses too. So initially you can get that kind of sleepiness, that lethargy associated with it. But as you pump the dose higher and higher, you start to see this excitation. And certainly, when we talked about toxicology, antihistamine abuse. So certainly one way that people, younger people who maybe have too much access to over-the-counter antihistamines and not enough wisdom to not abuse those, can get into some trouble with this when they start to get their doses really high. The one thing to note here as well, and we'll talk about first versus second generation antihistamines, but the second generation ones, basically their chemical structure is such that they have a permanent charge on them, what's known as a quaternary amine, and basically they can't cross the blood-brain barrier very easily. So that's why you see a lot less sedation with a second generation antihistamine, something like a cetirizine or Zyrtec or Allegra, something like that, because they just aren't getting into the CNS.
And is that for the second generation?
That's for the second generation agents, yeah. Some other effects you're going to be seeing specifically with the first generation agents is that they're going to be, and again, this is a lot to do with the antimuscarinic effects, is you're going to see they have some antiemetic activity. So really good for things like motion sickness, vertigo. Some of them are due to the antimuscarinic activity, they can help dry out the secretions a lot better. So you really will see much more drying effect with your first generation agents and really your second generation agents because they're not getting into the CNS to really do that. And then they can even have some anti-serotonergic effect as well, which clinically isn't really going to be useful to us right now, but just know that can be important for things like serotonin syndrome or something like that. So the antiemetic actions are going to be mediated mostly by the antimuscarinic actions, but they can also have some effects against the chemoreceptor trigger zone. Good, sure have heard of that before. And looking at something like promethazine or Phenergan, this probably has the strongest antimuscarinic actions, and so this is really good for motion sickness. This is one that has multiple dosage forms, so things like rectal suppositories. So that way, patients who are so motion sick and they're vomiting, like, it's a really good option for them, because that way they can at least get that exposure somehow, because otherwise they're going to throw it up. And again, having that antimuscarinic activity is going to be good for drawing out nasal secretions and bronchial secretions. But again, that's mainly going to be due to the first generation antihistamines, because they are able to get into the CNS and have that antimuscarinic activity. So again, our indications for our H1 blockers are going to be for allergic reactions, allergic rhinitis, urticaria, insect bites, drug hypersensitivity, whatever happens to be. Motion sickness, nausea, and other vestibular disturbances, so vertigo would fall in this category. Possible uses of OTC sleep remedies, and also as adjuvant roles in anaphylaxis. We'll talk more about that in the pulmonary section, but just know that this is going to be part of the cocktail that you would give for someone having anaphylactic reaction. Again, the adverse effects are going to kind of be extensions of their clinical effects. So certainly sedation is going to be one of the things. So some people may be using it for sedation, but that may be kind of an unintended side effect. For other people, I remember I had one time I was really, really ill, and I was just having terrible nausea, vomiting. My aunt was like, "Here, try this Phenergan." I was like, I didn't know any better, so I took it. I was out for like 12 hours straight. Like, it knocked me out something fierce.
But you were not sick anymore.
I woke up and I was not nauseous anymore. I did not throw up while I was asleep, so I was good. But I was out. Anywho, GI disturbances can pop up here, and then certainly things like dry mouth, urinary urinary retention, and blurred vision can be an issue with the antimuscarinic effects. In some cases, you may see some hypersensitivity, more like topical application of it, but it's a little bit, usually they're pretty well tolerated, so it's not really a common thing you see there. So here's the list of our first and second generation antihistamines. Probably take a break after this, but big thing to note here is if you're looking at the agents that are listed here, so things that are probably pretty commonly seen to you guys, especially on the over-the-counter standpoint, you'll see things like diphenhydramine, doxylamine should be on here somewhere. I guess I left that off the list, but doxylamine would fall in this category when we talked about earlier. Chlorpheniramine, diphenhydramine, all those things. Those are going to be first generations. They're going to cross into the CNS, and so when you look at their sedative effects and their antiemetic effects and the anticholinergic effects, you're going to see mediums to high for all of those, right? Whereas when you look at your second generation agents, things like your cetirizine, your fexofenadine, your loratadine, you're going to be seeing pretty low sedative effects, almost no antiemetic effects, and very low anticholinergic effects, because they're not getting into the CNS, right? So the way I liken it, is if I'm having, say I have pretty bad allergies to like animals and stuff like that. So if I know that I'm going to be going into an environment where I'm going to be exposed to animals, I would take a second generation agent before going, because I know it's not going to make me sleepy. I know it's going to prevent a lot of the histamine reactions from occurring. But say I unknowingly go into an environment with animals and I'm already having a runny nose and I'm just having this real bad allergic reaction, a first generation agent might be better, because they're better at dealing with those acute effects of that allergic reaction, right? So the second generation agents are really good as like kind of preventative, more like control medications, which is why it's nice to have long half-lives, because I can end up taking them once a day and kind of get all-day coverage for that, right? Yes?
So you're saying with the second generation you're not supposed to get it says like very low sedative effects, but I don't know. I take those, and I know a lot of people who take even those and they get really tired. Why is that? You just have more of an effect to the sedative effect?
It's a possibility. If you look at something like cetirizine, that's actually hydroxyzine or Atarax. That's actually a first generation agent. Cetirizine is actually a metabolite of that. So that's, if I see sedation to one of the second generations, it's usually going to be cetirizine. But it also seems to be like a little bit more effective, at least in the things I've seen, because it maybe is able to cross the blood-brain barrier a little bit better than some of the other agents. But yeah, some people are just going to be more sensitive to it than others. But in general, you're going to see a lot lower effects from those medications.
Right. Okay.
Yep. And then we'll have one intranasal antihistamine, Azelastine. We've already mentioned that back when we were talking about the ophthalmic antihistamines. This one will pop up here again as well. Okie dokie. Any questions from the first half of this? All right. Moving on. The thing we'll talk about here is this Azelastine or Astelin nasal spray. This is an antihistamine that's going to be applied intranasally, basically to deal with mostly just the kind of acute local effects of an allergic rhinitis. Certainly this will not work on any kind of systemic effects you may be having, but certainly if you're just having local rhinitis, this is going to be good for that. Remember we talked about this in the ophthalmic section. It also has some mast cell stabilizing properties, but really we're using it specifically as an H1 receptor antagonist. See here, it does have to be dosed a little bit more frequently, 1 to 2 sprays each nostril twice a day. Biggest complaints though are going to be usually kind of this bitter taste, and then potentially some patients may be more prone to nosebleeds than others, but it could be a possible side effect. Big way, or the best way to educate patients on how to administer nasal sprays. Obviously, you want to blow out the nose, clear the nostrils of any kind of obstructions that might be there. Typically, you have them tilt the head down and then kind of angle the spray away from the septum. That way you don't accidentally cause any injury there. So typically they'll say, like, for the left nostril, use your right hand, so that way you just kind of naturally will kind of aim at that direction, vice versa. You don't really want to tilt your head back when doing it, because otherwise you're going to have more of it getting into the back of the throat. It's where you can see a lot of bad taste from it. It can be absorbed more systemically. And then make sure they just clean it off well, because otherwise it can get kind of grody with nose stuff on it. And then we'll also talk about some corticosteroids that are important for ENT purposes. Again, we talked about their mechanism of action. They kind of work even higher up than something like non-steroidal anti-inflammatory drugs, because they go beyond even the cyclooxygenase. They're working actually at the site of the nucleus and altering gene and protein transcription in order to help decrease that inflammatory reaction that can occur. And if you had to imagine the onset of action, what do you think would be faster, an antihistamine or a glucocorticoid? Antihistamine, absolutely. So if they're looking for immediate effects, it takes time for corticosteroids to work, because it takes time for that gene transcription to be affected by that. So again, you're always going to get more bang for your buck immediately out of something like antihistamine, but you're going to get much more powerful kind of anti-inflammatory activity from a glucocorticoid in the long run. There's lots of nasal corticosteroids, and the benefit of these is you're not going to see a lot of systemic side effects, because we'll talk about them pretty extensively, but there's lots and lots of side effects associated with corticosteroids. And when I say glucocorticoids, corticosteroids, I'm kind of using those interchangeably. Majority of the corticosteroids you're going to see being used systemically are mostly going to be dealing with the glucocorticoid action versus the mineralocorticoid action. There's some that are more on that side. We'll talk about those as we get to them. Notice here there's actually some OTC varieties that are available now. So things like fluticasone, budesonide both have over-the-counter varieties, which is good for some patients. Note you really want to get the name straight on these, because there are a lot of varieties that are inhaled corticosteroids that are for asthma, and so the names are very similar. So there's lots of drug errors that occur here because the wrong product is being dispensed, because either the prescription wasn't written very clearly or the pharmacist accidentally dispensed the wrong product, whatever happens to be. This is a very common medication error that can occur. So things like Flonase, it's the nasal version, but Flovent is the version for asthma that's inhaled. And so a lot of things are saying, like, actually, if you just put fluticasone spray, that may not be enough. Somebody actually might grab the wrong box off the shelf. So that's why they always recommend actually putting the brand names for these, so that way you make sure you get it right. So instead of trying to think, Nasonex versus Asthmanex, you can see how those would be very easy to get confused if all you saw was mometasone on the prescription. So it's good to put the brand name in there in parentheses so that people can see which one you actually meant to prescribe for that.
Can I ask you a question about this?
Sure.
So when a provider sends the prescription through the electronic database, how does it look like in the pharmacist end? Like, does it ever say what it's intended for, or it just says give this patient this drug and fill it?
That's a good question. So it really depends on the system that you're using. So say for instance, like at Nemours, we had it set up very nicely because Epic was our computer physician order entry system, right? So Epic was the thing that on the inpatient side we used for all inpatient ordering. It's how prescriptions were generated through it as well. And so a lot of those defaults are already set up, right? So that way when you were to transmit a prescription electronically, whatever gets printed out at the pharmacy would say, use fluticasone, Flonase, 2 sprays both nostrils twice a day, whatever happens to be, right? So that information will all come across. However, in some systems, if it's not set up with all those defaults, then it might not come over. So it just depends on what you're actually sending to the pharmacies as to what they get. So in an ideal world, yes, all that information will come across. Things like PRN indications is another big thing that's possible for medication errors to pop up. If you just say, give as needed, instead of saying as needed for pain or as needed for fever or whatever it happens to be, that can be another source of medication errors. And so, if your system's set up to default that all over, then you're good to go, right? Good question. Yes?
Isn't like the CMS code or whatever that code, ICD code, for the diagnosis, is that not part of the prescription for you to bill for?
No, we typically don't get that on the pharmacy side. Or even if we did get, we wouldn't necessarily have, like, even if you just got the code, we wouldn't necessarily wouldn't know what to do with it, because we don't really deal with that in the pharmacy world, really. But in some cases you'll see, and because a lot of the indications you can kind of pick up from the dosage form. So if I see Flonase come across, like, I know what that's for, right? But for a lot of things, it could be very nondescript, and it could be a drug that could be used for 10 different things, and I just get the prescription. So in a lot of cases, it's very hard to know. That's why I like inpatient pharmacy so much better, because I can actually talk to the provider and say, like, what were you doing this for? And they'll be like, oh, I was doing this. And it's like, okay, that's cool, But
I'm thinking like in a Walgreens or CVS or something like that.
yeah, oftentimes you're kind of working a little bit more blind. You don't get all that information necessarily.
But even to bill their patient's insurance, they don't have to have a diagnosis code?
No, because a lot of times if you were to get like a medication that, say, is non-formulary for that insurance company, they would require prior authorization. And so then that will go back to the provider anyway to get that information all set up. Yep, good questions though. Okay, so again, so nasal corticosteroids, so the big things to note with these agents is that they do not work quickly. And the big thing is that they need to take it take it in a consistent manner for a long period of time in order for it to remain effective, right? So usually I say this is not going to be effective within the first week, so just continue using it. Even though you may not seem like you're getting better, you will get better eventually, because this is going to be very useful for specifically just these local effects within the nose itself. You're not going to get any systemic benefit from using these agents. If you stop taking it, the effects are going to go away as well, but just keep in mind that they need to keep on it and use this consistently in order to get the benefits from it. Again, nosebleed is a possible side effect with all these nasal sprays. The septum perforation is something that's a rare occurrence, but can certainly occur, because if you imagine, giving glucocorticoids, what does that do to wound healing? Slows it down, right? So if you were to have kind of chronic injury to the nasal septum over time, potentially having that chronic immunosuppression, that chronic suppression of wound healing could eventually lead to perforation occurring. So that is a rare side effect, but something that can occur there. Again, you administer this the same way as the other ones, so I won't belabor at this point.
Do they need a drug holiday like they did with other?
You typically don't need drug holidays from nasal corticosteroids. Yeah. Moving on, you can also, if you were having more systemic, severe reactions, you can utilize things like pulse dose steroids or short courses of steroids in order to help deal with that inflammation. So certainly in some cases, someone's having really bad bronchitis or something like that, you can get away with using short doses of steroids in order to help deal with that inflammation. So one of the common ones you'll see being used is dexamethasone, otherwise known as Decadron. Again, this is going to be working as a glucocorticoid. It's going to be useful for things like drug hypersensitivities or really any hypersensitivity, allergic rhinitis. You'll notice here that the side effects are going to be much more extensive than you would see with the nasal corticosteroids, because again, this is affecting the entire body. So certainly you can see some mineralocorticoid effects, things like worsening congestive heart failure, hypertension due to fluid retention can be a problem. Your diabetic patients, you can see more glucose intolerance, so you can end up seeing a patient can be very well controlled on their diabetic medications, on their insulin. All of a sudden, their blood sugar start climbing, and they can't figure out why. Chances are it's due to the corticosteroid activity. And then certainly you can see things like hirsutism, tendon rupture, potassium loss, all kinds of different things from the different adrenal effects. And again, the weakened immune system is important here as well. So especially patients who already have a compromised immune system, this could potentially make them more susceptible to having kind of a secondary infection popping up. Again, all the interactions that are going to be occurring are going to be related to the pharmacodynamic mechanism of the glucocorticoids. So again, if you're adding it with a antihypertensive, you're going to be seeing worsened effects from that. If you're adding on to diabetic medications, you're going to see worsened glucose intolerance. So again, all of them are going to be relating back to the mechanism of action of the actual glucocorticoids themselves. Big things to note with steroids is that typically if you're on doses for less than a week, you typically do not need to taper down the doses. And why would I ever need to taper down steroid doses?
Rebound?
Rebound what? So if I have my adrenal glands, right, they're chilling on top of the kidneys and they're sitting there, and all of a sudden they get systemic corticosteroids being administered to them, are they going to increase or decrease production of
Decrease.
right, so they're going to start to decrease. So you get this adrenal suppression that can occur, where if you were to withdraw the systemic corticosteroid you're administering exogenously, all of a sudden your adrenal glands take time in order to really kick back up. So you can end up seeing this adrenal insufficiency, you know, seeing issues with blood pressure and all kinds of different problems that pop up there. But typically, if you're on it for less than a week, you don't really need to taper down your dose of steroids. If it's longer than that, though, then you would need to build in a taper into it, where basically you just go, your dose would just taper off gently. Usually, say over the course of a week or so. So for patients who are just receiving it, say for like an acute asthma exacerbation or acute bronchitis or something like that, typically you'll have like a Medrol dose pack, which is methylprednisolone, that already has a taper built into it, but you don't necessarily have to do that if it's for short courses. Make sense? Okay. Another common one you'll see being used in the kind of more acute care settings is going to be prednisone / prednisolone. Prednisone is the oral tablet form that you can take, and there's also prednisolone, which is actually the active form. Prednisone actually gets converted over into prednisolone, but it comes in the liquid preparation. Again, very similar side effects you'd see to dexamethasone. They're all working very, very similarly. Really, only difference here is that dexamethasone has a little bit longer half-life than prednisone, but they're almost identical as far as side effect profiles go and all of that. Again, if you're taking it for longer than a week, then you would not want to discontinue use abruptly. Otherwise, you should be good to go if it's only 5 days or something like that. Okay, then we'll talk about decongestants. So this is a very common over-the-counter nasal decongestant seen being used, Afrin, otherwise known as oxymetazoline. We talked about this previously in the ophthalmic section. Again, this falls into that category of an imidazoline derivative. Right, so it's going to be working by constricting blood vessels. Anyone know which receptor it does that through? Yeah, so locally it's going to be acting through alpha-1 receptors, but again, remember these are traditionally, if you were to administer systemically, it's the alpha-2 activation up in the CNS, but it's working through alpha receptors to cause vasoconstriction, which is going to be good if you have a big runny nose and you're having all this fluid leakage that's happening there. So these are very, very useful for constricting those vessels and dealing a lot with that nasal discharge. The big thing here is you want to limit how long they're going to be using it. No more than 3 to 5 days. Why do I want to limit the use of it? Basically, you become dependent on it. You get this thing called rhinitis medicamentosa, and essentially what it is that your nose gets so used to having that alpha activation down. Those alpha receptors are constantly activated. What happens to the receptor count? Does they upregulate or downregulate? They downregulate, right? So all of a sudden, if I were to take away that vasoconstrictor properties, what's going to happen to those blood vessels? They're going to open wide open. You're going to have lots of discharge. It's going to be very, very difficult for you to really get a hold of that anymore. So if you limit how long you're going to be administering it for, then you limit that rebound effect that you're going to be seeing, this rebound rhinitis that you see. There's one pharmacist that was working, used one of our preceptors, essentially hit a big long counter, is at a Walgreens or something, and he basically had 3 bottles of Afrin interspersed throughout the thing, so that way he could always get a hit wherever he needed to, because he was using it for such a long time that he was basically addicted to it in a way, because you become so dependent on having that alpha constriction around. So again, make sure your patients know not to take this longer than 3 to 5 days, otherwise they're going to have rebound congestion. It's going to be really, really bad for them. Probably even worse than it was when they were taking it in the first place. Also, the vasoconstrictor properties can be an issue if you have patients who have hypertension, maybe blunt the effects of how your antihypertensives are already on board anyway. So again, same administration you would see with the other agents. Other popular decongestion, this is going to be more of a systemic one. This is going to be pseudoephedrine. You guys remember what's specific about this, the control of this medication? Yeah, it's behind the counter. It's not really, it's not really controlled substance, but certainly you have to provide your license, because what can you make from this? Methamphetamines, absolutely. So certainly the kind you'll typically see, like on the over-the-counter shelves, is going to be something like Sudafed PE. Does anyone know what the PE is? phenylephrine, right? So it's kind of a weak, wimpy version of it. I never recommend that. So just go get the stuff behind the counter. It actually works better. So I won't talk about it too much, but the activity between pseudoephedrine and phenylephrine is very similar. What they do, just a phenylephrine is a much weaker kind of variety of it. But pseudoephedrine, again, this is going to be working systemically to work to constrict those blood vessels by working through alpha activation. Again, you're going to be seeing more systemic side effects due to this. So you can see more hypertension, tachycardia, headache associated with this. So this is going to be, not recommended for patients who already have, things like, angina that might be more predisposed to, coronary ischemia, or they have headaches, due to their hypertension, things like that. So that might be better for them to use kind of a more locally acting product like an Afrin versus utilizing something more systemic. And then we have one mucolytic agent we'll talk about. So it was known as guaifenesin. Mucinex is a common brand name you'll see for this one. This works basically to help loosen up mucus secretion, especially things like down in the lungs. Helps to decrease the viscosity of it. So essentially it makes it easier for you to kind of expectorate that and get rid of it. Big thing to note with this thing is you really want to take it with lots of water, because otherwise if you have just the secretions you're trying to kind of loosen up, you need to have liquid in there in order to decrease that viscosity. So lots of water to take with this and help them expectorate that. But really not a lot of side effects or drug interactions. It's actually a very well tolerated medication, but probably not as super useful as one might think. But if you have just kind of thick, gunky secretions and you need to get rid of them, this is a good way to loosen those up. Again, tell and let them know that when they are taking this with lots of water, they should expect to see an increase in the amount of drainage or an increase in the amount of coughing up a phlegm and things like that. But just know that you're getting rid of it. It should dissipate over time. Okay, so any questions on the ENT stuff? Would anyone like some review time?
Yes.
All right, okay, yes, that sounds like a resounding yes. So what questions can I answer for you guys? Not all at once.
I have a question.
Yes.
So there seems to be a lot of overlap as far as drugs that can cover intra-abdominal infections. Could you give us like a lineup of drug of choice we want to use for any intra-abdominal infections?
Absolutely. So intra-abdominal infections, the two types of bacteria you're really worried about are going to be what? So like gram negatives are going to be a big one. Enterococcus, probably be another one you're worried about. And then what else? Anaerobes are going to be huge, right? Because again, the gut's just harboring all kinds of different bacteria. Those would be the big ones. So I don't need things like MRSA coverage. I don't need coverage for things like that. So really, those are the big things I'm focusing on. So the big medications that are going to be useful for that, Zosyn, like piperacillin tazobactam, is a good one for things like complicated intra-abdominal infections. So if I was worried about like a complicated appendicitis, that's a very good one to go to. So piperacillin tazobactam has good gram-negative coverage, has good anaerobic coverage. That's a good option. Also, I oftentimes will see things like metronidazole in combination with like ceftriaxone. See, that's a good combination because it's able to hit all those bugs at the same time. Remember, Enterococcus is kind of a blind spot for all the cephalosporins, kind of as a class, but I see that as a common one, especially for kind of uncomplicated intra-abdominal infections. So that's a good one for, say, like surgical prophylaxis. You get with like ceftriaxone and metronidazole at the same time, because metronidazole is really going after your anaerobic bugs at that point.
Okay, so that's just those two.
Those are the main ones that I see. But again, as long as your bacteria or your antibiotics have coverage for those type of bugs, like that's going to be enough to cover it, right? Sometimes you'll see things like Bactrim, sometimes used for some like like Shigella, things like that, like traveler's diarrhea. But those are the main ones I see in clinical practice, with like a lot of our general surgeons going in for treating appendicitis and things like that. Because you wouldn't want to use something like cefepime for an intra-abdominal infection by itself, because it doesn't have anaerobic coverage. That's why like piptazo is preferred in that realm. Yes.
For macrolides and one of the other ones that affect the cytochrome P450. So if a patient is not taking like the medicines that are substrates of that, are there other things that macrolides can affect in the body? Like what are the other substrates?
Yeah, so basically the CYP3A4 is really just concerned with drug metabolism. If they have by inhibiting those enzymes, I'm not aware of any other like physiologic effects you would expect to see with something like like an erythromycin inhibiting those enzymes. Really, the drug metabolism thing is a big thing to focus on with those. Yep. Yes.
So for the test, are we expecting like you have this infection, what do you treat with, or this drug, what is the mechanism of action, or how should we?
Yes. No, so there's a variety of questions. Obviously, there's going to be a couple of ones that are just basic kind of regurgitation of information. So certainly there's going to be like, which one of these inhibits bacterial protein synthesis? Which one of these is a third generation cephalosporin, or which one of these is a second generation, whatever it happens to be. So there's some questions like that. I try not to have too many of those because I don't think those are super useful for you guys in the clinical world. I do like questions, say like, you have a patient who's coming in, you are concerned about them having osteomyelitis due to MRSA. What would be a good empiric antibiotic to administer? And you might say? Vancomycin is a really good one. Like vancomycin might be a good option. Something like linezolid might be a good option. Right, so I might put that, or a question like that. So yeah, kind of yes to both of those questions. I might ask also, like, which one of these would be most likely to cause this side effect? Or I might ask, say, you're worried about this type of infection and this patient has this allergy. What would be a good option for them? So say for instance, I put, patients coming in, you're concerned about cellulitis and they have a sulfonamide allergy. What might be a good option for them? And so you'd have something like, clindamycin might be a good option, or it would be the correct answer, and then you have a bunch of other stuff that really doesn't cover gram positives, right? So those would be the kind of questions I might ask.
But if the infection itself, would you specify whether it was gram positive or gram negative, or would sometimes you just wait no?
Yeah, I'll usually specify the bugs unless I'm talking about something like we covered here. So if I'm talking about like acute otitis media, I would expect you to know what the causative organisms already are for that and know that, okay, this is what I know I'm covering for, here's my alternatives. So I might say like, patients coming in, 6-year-old patient has, strep pharyngitis, they're not able to keep anything down, what's a good option for them?
And you would also in turn ask like, okay, the patient has enterococcus, what's a good one?
Yeah, exactly. So, I might say which one of these would not cover an enterococcal infection. I might put it like a cephalosporin, Or say like, I have an 8-year-old patient, which one of these medications would be contraindicated for them? You might put something like a doxycycline, right? Because it can worry about like, teeth staining and whatnot.
As far as different treatments of acquired pneumonia, there seem to be a lot of overlap as well. Whether it's hospital or community or what have you.
Yeah, I won't really go into that until we get to the pulmonology section. So there's not really much on pneumonia.
Okay.
I use that as a common. I use pneumonia as like a common example, just because there's lots of multi-drug resistant. The spectrum of pneumonias from community acquired to like hospital acquired pneumonias and like ventilator acquired. There's such a good spectrum of different bacteria that could be responsible and the different antibiotics you might use for it. So I like to use those for examples mainly, but probably not really any questions on that for the most part. Yes.
It feels like some things have a lot of side effects and interactions and things. Is there something particular we should be focusing on?
Yeah, focus on unique things to kind of each of the classes. So say for instance, if there's something like tendon rupture, what would you be thinking of? Fluoroquinolones, right? If you're thinking of teeth staining, you think tetracyclines. Yeah. If I'm thinking like QTC prolongation, what might you think? Macrolides and fluoroquinolones, right? If I say which one can cause diarrhea, that's all of them. Like they can all cause diarrhea, right? But say like which one is more likely to cause C. diff? Yeah. It's like clindamycin, right? So we say clindamycin is more likely to cause C. diff. And then what would be good to treat C. diff?
Vanco orally.
Vanco orally is one option. What's the other one? Starts with an M. Metronidazole, right? That one you can use either IV or PO, right? So focus on kind of like unique things about them as far as like side effects go. Because like rash, if someone calls like Stevens-Johnson's, like I'd probably focus on that because that's a very severe reaction you should be aware of. But if it's like nausea, vomiting, like don't focus on, because anything can cause that really. Yep.
What about the way you
It could be important. So, look at your patient factors that are involved with that, and that can make a difference. So, obviously, your patient is uncontrollably vomiting, oral route might not be a good option for them, right? Things like that. You may see, like, again, I put, brand name and generic name on the test, so you guys can reference those if you need to. If you see anything where, like, I give you a couple different drug options and I give you, like, dosing afterwards, like, don't get caught up on the dosing. Like, you weren't expected to memorize that. I just put them as examples, right?
Wait, are you using the brand name
And generic. Yeah, those would both be on the test.
like in the same?
Yeah, so it'll say, like, ceftriaxone, parentheses, Rocephin.
Awesome.
Yep. Yes.
As far as time dependent versus concentration dependent, do you want to know, like, for each drug, if they are going to be, like, which one they are?
I would have a good idea of which camp they really fall into. Yeah, that would be good to know.
Each drug, or like,
Just in general, you can kind of pick it up over time. So I'd probably be more focusing like on the concept rather than it's penicillin a time versus concentration a bit. But I might say, this drug is dosed 4 times a day. Would that make you think it's concentration or time dependent?
okay.
Something like that. It's more of the concept than it, because like clinically, you don't really need to know that penicillin's a time dependent, but you do need to know that you need to know that when you see it's every 6 hours or every 4 hours, why that is and why it's so critical that they get it every 4 hours, because if they drop below that MIC, it won't be working, right? So what can change your iris color? Yeah, prostaglandins in general can change eye color. It also cause, what's the kind of pro thing it does? Yeah, it causes your eyelashes to grow. Let's see what else. What's kind of like your go-to glaucoma medication? Like drug class-wise, which would you go to first? Some people go beta blockers first. Some people do prostaglandins first. Yep, both are, I would say, are fine answers. What's a potential side effect of beta blockers? Good, asthma exacerbation, except for which one? The betaxolol, right? That's the one that's cardioselecta, is the beta 1 selector, right? Because again, it's primarily in the lungs, which receptor? Beta 2, right? So if I use a non-selective beta blocker, I'm potentially blocking those receptors, right? Good.
Yeah, I know this is kind of specific, we can talk about it later, but what are these drugs? Why have you got them off the side in this?
It just kind of, so that slide is referring to the one with the looking at AUC versus MIC and all of that. Really the point to take away from that slide is that when you're looking at time-dependent killers, like the AUC needs to be above the MIC as much as possible. So the higher that is, the better off you're going to be, versus something like it's a concentration-dependent killer. Even if your drug drops below the MIC, it's still going to be effective because there's that post-antibiotic effect.
So these here are still effective under the MIC, you're saying?
If they're a concentration-dependent killer, yeah.
Gotcha.
So the AUC has to be above the MIC if it's time dependent?
Right, because you want that to be as much of the AUC above the MIC as possible. Anything else? So say I had a patient with fever and they had a history of gastric ulcers. What might be a good option for them?
Tylenol.
Yeah, acetaminophen is going to be a better option for them, right? Because it's not really affecting the COX-1 and COX-2 enzymes, more affecting COX-3. It's a good option to know. Let's see what else. What's the problem giving aspirin to young children?
Reye syndrome.
Yeah, Reye syndrome is going to be the big thing there. Has anyone ever seen the movie Black Mass? Johnny Depp? Super depressing, but there's actually a case of Reye syndrome that's in there. Not necessarily all due to that, but that's there. Any other questions? Yes.
For the aminoglycosides, why do you need the trough to be below a certain number?
Mm-hmm. So with aminoglycosides, those are going to be concentration-dependent killers, right? Traditionally, they used to be dosed every 8 hours for like everybody, right? But then they kind of realized that you don't really need to do that because that's a post-antibiotic effect and all that. So when you are dosing aminoglycosides, usually you're dosing, say, every 24 hours, typically, right? So the point is when you give a big dose and you're doing it like a milligram per kilogram dose, right? So you know that based on the dose I'm giving you, I know your concentrations are super high, right? But the thing I'm doing is to make sure that your troughs are low enough, because say you had renal dysfunction and you weren't clearing the drug as well. If I were to check a level and it was really high, that may lead me to say like, well, you're not clearing as well. Maybe I need to give it to you less frequently to give you more time to clear it. So maybe I need to give it to you every 36 hours, every 48 hours instead of every 24. Same thing with vancomycin, because you worry about the longer you accumulate those troughs and the higher kind of level is over time, like the more likely you are to develop some of those toxicities. So again, with vancomycin, you're more doing it to make sure the trough is above that MIC, but also if you're getting your trough too high, that could also mean you're accumulating and you're more at risk for toxicity. And with some of the big toxicities you see with things like aminoglycosides and vancomycin. Ototoxicity and renal toxicity, yeah. Yes?
I'm struggling with the CYP interactions and why.
So why it's important, or?
I guess, what does it mean when a drug is CYP interactive?
Yep. So so medications can either be a substrate for a CYP enzyme, they can be an inhibitor, or they can be an inducer. They may not have anything to do with it. But essentially, when we're talking about drug interactions, it's one of those three things. So you know, you could have many drugs on board that are all substrates, which just mean they get metabolized by CYP3A4, right? You can have your inhibitors, which will inhibit the enzyme from functioning. And what is that going to do to your levels of your substrates?
Increase them.
Yeah, they're going to go up because the CYP3A4 is not working as effectively to metabolize those drugs. So I'm going to see increase in levels of those. And on the other hand, if I had a CYP inducer, I'd have a higher number of those enzymes. It would cause my drug levels to go down because they're more effective at metabolizing those substrates now. So when we talk about CYP interactions, saying things like, you know, say clarithromycin, if I have a drug that is metabolized by CYP3A4, I run the risk of having toxicity with one of those other ones on board because I end up driving up my levels and I'm more likely to see side effects. So when we talk about like the anti-lipemics in the next section, so we're talking about HMG-CoA reductase inhibitors, otherwise known as your statins, things like simvastatin, atorvastatin. Those are big CYP3A4 substrates, and so you can run into some really, really bad interactions if you were to have an inhibitor on board, because you can run the risk of, you know, hepatotoxicity, you know, muscle toxicity, all kinds of stuff. So it's a very important concept and important to realize what those main inhibitors are. Other questions can answer. So the test is on Wednesday, right? So I'll try to respond to questions as much as possible. I'll get this uploaded as soon as I get back to my office. Other than that, you can email me. I'll try to get back as much as I can before the test. And I'll try to be here on time to proctor my own exam. This is my first time, so I was very lost. Anywho, okay, anything else?
Oh yeah, MSSA, what do we use for MSSA?
Good. So MSSA, you'll see that. So typically, when you're trying to cover empirically with an antibiotic course, you'll get things that are more broad spectrum than just covering MSSA. So certainly things like, you know, third generation cephalosporins will be good for that. You know, clindamycin, Bacterial, all kinds of different things could potentially cover MSSA. When you see that when you culture it out and you see that that's what you're growing, and it's sensitive to things like your oxacillin, dicloxacillin, things like that, that's usually when you scale back your therapy to use one of those anti-staphylococcal penicillins.
So any like penicillinase resistant would you use, is what you're saying?
Right, so if it's MSSA, you know it's going to be, you know penicillin's not going to work for that, right? You need anti-staphylococcal penicillin for that. Because penicillin itself will not cover MSSA.
Okay.
Yeah. Anything else? All right. Well, I will see you guys Wednesday morning then.
How long are you on campus today?
How long do I need to be on campus today?
Never mind, we have another lecture after this.
Yeah, I have another lecture. I will probably be gone by then, maybe. We'll see. See if I get some work done. You can just stop by. Yeah, you can email me. I'll try to get back to you guys. Cool. All right. See you next time.